Hello, everybody. Good morning, good afternoon, good evening, from wherever you are in the world. It's great to see you sharing that information with us in the chat. We're here today for the next in our Innovation at Work webinar series. And today we have a deep dive. We're going to spend a full hour diving into today's topic about COVID-19 in the company of Professors John Sterman, Hazhir Rahmandad, and a PhD student from MIT Sloan School, Tse Lim. Thank you, John, Hazhir, and TY for joining us today and for talking about this important topic and for presenting your new work in this area in what I know is going to be a very interactive and engaging experience for the next hour. So with that, I know we've got a lot to get through, so I'd just like to hand over to you, Professor John Sterman, and let you introduce this topic.
Great. Thank you, Peter, and welcome, everybody. I see we have folks from all around the world. We appreciate it. So we're going to talk about our new work on the progression of the COVID-19 epidemic around the world. You can see some of the issues we're going to address here on this slide. Let me just say that this team, primarily Hazhir and TY, with some help from me, we've developed a set of papers that analyze these different questions, and all the papers that we're presenting and talking about today are freely available as preprints. The work is under review at various journals. So with that, we've got some questions for you. There are some questions on the screen here, but we want to get your views to kick this off. So we're going to do a couple of quick polls. TY, if you can make sure the link to the poll is in the chat, and I see it's now posted in the chat. So today, as of just this morning, the official count of cases is worldwide. 107 million people have been confirmed as having contracted COVID-19, and over 2.3 million are confirmed as having died. So let's take a look at the first poll. We want to know your view of how the actual number of cases compares to those official counts. So there are 4 choices. So click on the link in the chat. It'll take you to this poll. There are 4 choices. You have to vote. And your choices are that the true count of cases is 3 times more than the official count, 7 times more, 11 times more, or 15 times more. Go ahead and vote. We will display your results in a minute. I see we've almost got 100. There we go. We've got 100. Keep them coming, folks. It's important for you to have some skin in the game here. We want to know what your view is on the true magnitude of the epidemic compared to official reports. So go to the poll if you can. And we're up to about 170 responses now. That's great. Keep them coming. A couple people pasting their answers into the chat. A few for 3, a few for 1 for 7. We'll show you the results in just a few moments. We're almost at 200 responses right now. So I think we could show those results, and it's a pretty wide spread, pretty evenly divided between 3, 7, and 11, with about 1/3 as many voting for 15 times more. Great, you can keep answering, but we have a couple other questions for you. So Hazhir, what's the next question for everybody? So this graph shows you throughout the pandemic, so from March 1st of last year to the most recent data, the death rates in different countries per million people per day. So how many people die per day of COVID-19? And the critical thing to notice about this graph is that the vertical axis is a logarithmic scale. So at the bottom, you have 0.001 per million per day, then 0.01, 0.1, 1, and 10 deaths per million per day at the top. That means that there's a variation of more than 100 times across countries. And the question for you all is, what is the best explanation for this enormous variation in death rates across the different countries of the world? So let's take a look at that next poll. Same link. And here you go. So your choices are undercounting varies by country. Perhaps it's differences in the age distribution. Some countries like Italy, for example, or Japan have age distributions that are tilted more towards the older end of the distribution compared to, say, some countries in Africa or Latin America. Maybe it's variations in healthcare quality or healthcare capacity. Maybe it's different policy and behavioral responses to the pandemic. Maybe it's weather or geographic factors or something else you may think of. So go ahead. We've got about 120 responses right now. Let's see what you all think. Okay, different genetics showing up in the chat, healthcare, different responses. The link to the poll has been pasted into the chat again, so you can just click on it to see what's going on and take your vote in the poll. And here we go. So over a third, almost 40% now for undercounting. The next most popular answer is different responses in policy and behavior. And then we have a smattering of the other choices. So that's quite interesting, quite a divergence of opinion here as well. All right, let's go to the next question. So most of the discussion in the media and in the policy circles has been around this idea that there's a trade-off, that you can save more lives but harm the economy, or you can save people's livelihoods, their jobs, their businesses, but more people will die. So our question for you is whether you think there's a trade-off here between saving lives and saving the economy, or perhaps you think there's a synergy that you can do both, or you can have a worse economy and more deaths, or maybe there's no relationship here. So let's go to that poll. And the question is there a trade-off? Is there a synergy? Or is there no relationship between the amount of economic harm resulting from control policies and the death rate from COVID-19 that results? If there's a trade-off, more economic harm, save more lives. But if you weaken economic harm, then more people will die. If there's a synergy, then the more people who die, the greater the harm to the economy would be, and vice versa. And if there's no relationship, there's no trade-off. So what do you think? Got a couple of different votes in the chat. Good. This is really valuable for us to get a sense of where you all are. And it's, well, the majority is for synergy, no trade-off, but 36 and growing are arguing for the trade-off, and about 1 in 8 for no relationship. Terrific. Okay, let's see what's next. So at this point, we thank you for your views. We're going to come back to all those issues as we go through this, but right now we think it's important to spend a little time explaining how we did the analysis that you're about to see. So I'm going to hand it right off to TY.
Thanks, John. Hi, everyone. So to answer some of these questions, what we did was we developed a system dynamics model of the pandemic. I know there's a lot going on here, so let me give you a quick overview of the model. So the core of the model is your basic SEIR structure that many of you may be familiar with. Now, this structure is standard in infectious disease modeling, and it's the basis of pretty much every COVID model that you'll see. So you have susceptible people who can get infected. They can get infected through contact with infected people. And once they're infected, they become exposed or pre-symptomatic, where they've caught the virus, but they haven't fully developed the disease yet. And then after some incubation period, they become infectious. And then after that, after some more time, they either recover or they die. So that's the basic structure. And then what we do is we disaggregate this structure further. We track testing and hospitalization, so who has or hasn't been tested, as well as who is or is not hospitalized. And we do this endogenously. So the rates of testing are going to depend on the test capacity available and so on. And these different states are going to affect the transmission of the disease as well. So people in different states, tested versus not tested and so on, are going to have different transmission rates because, for example, somebody who has received a positive COVID test is going to be more likely to be quarantined and therefore transmits to fewer people than somebody who hasn't been tested. We also add another really important feedback process, and that's the behavioral response to risk. So as the threat of the pandemic gets worse, quick please. As the threat of the pandemic gets worse and you have more deaths and more risk of infection, then people become more likely to stay at home, for example, or to wear masks to avoid large gatherings and so on. And this combines whether people are doing that voluntarily or whether it's mandated by government policy. So people try to bring down their exposure, and that brings down infection rates. There's also some adherence fatigue. So as the pandemic wears on, people get habituated to the risk and they become a bit less responsive. So we take this basic structure and we apply it simultaneously to 92 different countries altogether, covering about 5 billion people. And we use data on reported cases, reported deaths, as well as testing and vaccination to estimate model parameters. The parameters we estimate include both biological parameters, things that reflect properties of the disease, like the fatality, its transmissibility, and so on, as well as behavioral parameters that govern the risk response, the test capacity allocation, and factors like that. Next slide, please. So based on this estimation, we are able to fit the model to observe data pretty well across most countries. Now, it's not perfect, but considering that it's the same structure applied to every country, just with different parameters, it's fitting pretty well. And most importantly, what we can do, what the model can do rather, is generate the multiple waves or the patterns of multiple outbreaks that we see in many countries. And this is happening endogenously based on the behavioral response to perceived risk from the pandemic. And that the fact that it can replicate this across multiple countries simultaneously gives us some confidence in the model's accuracy. Next slide. And what we find is across different countries, there are far more COVID cases than officially reported. So to those who answered 7 times just now, congratulations, that's about what we found, about 7 times as many cases and about 1.5 times more deaths. But this is varying widely across different countries. So for the US, for instance, we see about 3 times as many cases as reported. The UK is at about 5 times. Mexico is closer to 30 times. There's a lot of variation, mostly depending on test capacity. One of the reasons why there's so much underreporting is a lot of cases are asymptomatic. We estimate that asymptomatic fraction at about 50%. We also find that infection fatality rate is about 0.5%. That's the average chance that someone who gets infected is going to die. Now, there's going to be some variation across countries, mostly due to demographics. As John said earlier, older countries like Italy have higher infection fatality rates than younger ones like Kenya. We also find hospital capacity makes a big difference here. So if you can get a hospital spot, on average, your chances of death are cut by about half compared to if you don't get a hospital spot. And that really highlights the importance of not overwhelming healthcare capacity and hospital capacity through surges in infection. So that's, you may remember about a year ago, people were talking about flattening the curve. That really shows the importance of flattening the curve in that way. Now, fatality rates have actually been going down over time. Partly that's because our treatments have improved. Medical professionals have gotten better at dealing with COVID cases. But it's also partly a self-selection effect, where early on, a lot of more vulnerable people, older or people with comorbidities, were getting sick and more likely to die, whereas more recently, on average, people getting infected have been younger and less likely to die. Okay, with that, I'll go hand over to Hazhir, who'll talk through a couple of scenarios.
Thanks so much, Tibai. So now that we have a model which can closely replicate the historical trajectories, including behavioral and policy responses and changing fatality rates and even vaccination, let's put the model at work for understanding future trajectories. So we have done so by building a simple interface to interact with the model. And here is what it looks like, this interface. And let me actually, so here is the link to the interface in the bottom, and I think TY will be posting it on the chat so that you can actually use it. But for now, what we want to do is to go through a couple of scenarios together. So let me bring it up on the browser myself. And okay, so what happened? So here is the simulator. This is designed to project the likely trajectory of the pandemic across 92 different countries for which we have good estimates for various effects we discussed. It's based on the model we discussed, and it is calibrated regularly so that it is up to date with the most recent data. We actually did the latest calibration this week. And here on the upper right corner of the graph, you can select the country that you want to look at the results for. And below that, there are the inputs for setting up a scenario that you want to run. And we focus on two specific issues. One is vaccination. For vaccination, we include three different parameters: the start time of the vaccination, the length of the vaccination period, and the magnitude of vaccine hesitancy, and what fraction of people who are not willing to get the vaccine. So those are the three inputs in the green space here. And then below that, you can change the responsiveness. The responsiveness input determines the levels of perceived risk, the levels of deaths that essentially compels the community in this country to change their behaviors notably. We have estimated those levels across different countries in our sample, and it varies quite significantly by orders of magnitude. So a 20 to 30% change in those levels is pretty comparable to dialing back the adherence fatigue in a given nation. On the left-hand side of the graph, we have different outputs. So here on the bottom, we have the historical data in dotted lines compared with model simulations. And what you can see here, and this is for the USA, is that the model closely replicates the US historical trajectories for cases that are in blue with the right y-axis, and deaths, which are in red with left y-axis, including three distinct waves of the pandemic to date. The dotted vertical blue line here shows the date of the last data point used in the calibration, which is pretty current in this version of the model that is currently online. On the left-hand side, the graph shows the actual number of new cases and deaths. And comparing the scales of the graph on the left versus the one on the right, you can see the actual numbers for the USA have been a little bit over twice the official numbers for the cases. And deaths are much closer, but there is still undercounting in the US. We estimate that to be around 10 to 20% in this model. On the top left, we look at the cumulative number of cases and deaths. And below that graph, we have the cumulative deaths and cumulative cases by the end of 2021 when we simulate the model. In this baseline simulation that you can see, there is no vaccination beyond what has already been done over the last month and a half. And with that scenario, we get to about 770,000 deaths by the end of 2021. And finally, on the top middle, we have a few other measures that are interesting and relevant. So the yellow line shows the fraction of population that is susceptible to getting COVID-19. Green is the fraction of population that is vaccinated. Note that in this baseline scenario, vaccination is put to 0 after the historical data for vaccination to date, which is about 7% in the US. And then finally, the purple line tracks changes in the interaction level compared to pre-pandemic levels. So the closer that number is to 1, the closer is life to normal. So now let's run a couple of simulations. First, what happens if we vaccinate everybody across the world over the course of 2021 in a constant rate? If the vaccine is fully effective and if there is no vaccine hesitancy. To run that simulation, we simply need to change the time to finish vaccination to 365, or 360. This is assuming that we start from beginning of January, and we can simulate the model. And the trajectories start to diverge from the original simulation after the current date. And what you can see is a relatively notable change in the total cumulative deaths. We go down to 664. That's more than 100,000 lives saved as a result of this scenario of vaccination in this case. So let's now look at a second scenario in which the vaccine production is halted. There is no more vaccine, but instead of vaccination, we look at the impact of responsiveness. So let's increase responsiveness by 20% and see what happens. So I bring vaccination to 0 and increase responsiveness by 20% and simulate this scenario. Now, this time deaths go down to 715,000 from 770 in the base run. Not as big of an impact as the vaccination for the US is, but it is pretty significant reduction. Also note that the responsiveness comes only with short-term costs in terms of interactions. So the purple line has gone down significantly for less than a month, and then it goes back to kind of the baseline trajectory. So you can go on and kind of design and compare various scenarios of your own. And here we just looked at the US. So let me show you what happens in these two scenarios when we add up the tolls across all of the countries. So in the next slide, I'll be switching to that view. So here we are showing the cases and deaths until cumulatively until the end of June 2021 for 4 different scenarios. That solid lines, deaths are on the left. The solid line is the base case, no vaccination. The dotted line is with 100% vaccination over the course of 2021. We are just looking at the results until end of June. And when you have more responsiveness compared to having more vaccine, in the second scenario, there is no vaccination, you actually overall get a better return in terms of saving lives. And of course, when you combine these two together, you get to the third line down here, that is having both vaccine and more responsiveness, and that saves even more lives. Overall, in the shorter term, that's in the next 3 to 5 months, the vaccine impact is somewhat modest because the perception of reduced risk leads to reopening, less masking, less distancing, and that increases contacts, cases, and deaths compared to if the public health recommendations were adhered to just as it was without vaccination. And that's kind of a tension that we hear in the news and in the kind of public health suggestions. So Biden urges America to mask up for 100 days as coronavirus surges and hang on for 3 more months. On the other hand, we do see openings in the society. So just Massachusetts from yesterday start relaxing capacity restrictions for businesses and so on. So that's an example of these scenarios you can run, and feel free to run that using the simulator. For any other countries, you can check the results. Let's go now to the other question that we discussed, and that is the issue of trade-off between public health and normal activity. So remember that there are more than 100 times difference in death rates across countries, and many of that is due to different responses across the countries. At least that's what you thought is the one of the major reasons. Now, if we go with that premise, then there is a question. Did countries face a notable trade-off between saving lives or the economy or not? And the trade-off idea is pretty salient in the public discourse and in the policy circles. It also sounds intuitive. We all have sacrificed many normal interactions in light of the pandemic. And you hear it in the news. So the COVID-19 dilemma, public health versus the economy. Maui just had to kind of make this decision, how much do you close down the economy, and which devastates it, but they have surging case numbers. The UK Labour Secretary was saying that Johnson's government had to balance protecting people's lives against keeping people in education and employment. We see this happening across different states in the US. The Wisconsin governor just issued a new mask mandate as soon as the Republican legislature eliminated previous mask mandate. So this is pretty hot topic, and people are kind of pushing on and pulling in different directions. And if there is a trade-off, and if that trade-off framing is correct, it does provide a more rational explanation for differences in death rates that we are seeing. You can say essentially some countries may be putting more emphasis on economic activity, so they have traded off lives for livelihoods. And some countries may have chosen the other mix and anywhere in between. But is it really the case? So we look at 3 different lines of evidence to assess these questions. The first line of evidence comes from looking at historical data. Here on the right, we have graphed for various countries across the world the average death rates over the past 6 months It is the y-axis, and note that it is also a logarithmic scale. So you do see the 2 to 3 orders of magnitude change in the average death rate on the y-axis. And we have graphed that against the effective reproduction number on the x-axis. So what is reproduction number? It is the average number of new cases each infected individual will generate. If this number is below 1, the cases will be falling because each person does not create a replacement case. And if this number is above 1, we are in this region of the graph, and the cases will be growing exponentially. At the start of the pandemic, this number was around 3 to 5, depending on the community. So that resulted in pretty rapid exponential growth in cases and deaths, which in turn led to significant contact reductions, which brought down the reproduction number because people were seeing the huge impact of the pandemic. So that brought down the reproduction numbers to what we're observing, which over the past 6 months, the reproduction number has been largely around 1. That's actually the natural equilibrium in this system. If the reproduction number is above 1, cases and deaths will grow exponentially. That raises fears and people have to close down. And if it is below 1, the deaths go down and people relax. So that's kind of the inherent attractor in this system. But what reproduction number of 1 imply is that all countries have had to bring down their contacts about the same amount, which leads to our interesting finding here, that all countries are forced to bring down their contacts about the same level because otherwise the epidemic continues to grow exponentially. But they can do so at very different levels of death. Essentially, the level of death that compels the community to bring down their contact rates to what is needed for a reproduction number of 1, that level becomes the inherent, the kind of continuous death rate we're observing in these countries. And as we estimated, those levels are very different, 2 orders of magnitude different. So that's one line of evidence. Now we can use our model simulations to look at the levels of change in contact rates relative to normal pre-pandemic levels against the death rates. Again, logarithmic scale, 2 to 3 orders of magnitude variation. And again, we see the same dynamic that after the first wave, behavioral feedbacks dominated the dynamics. Once the cases started to fall down, the perceived risk started to go down. It led to more reopenings and then brought back the reproduction number. And we see that essentially the variations in contact rates are relatively modest. They are between 50-60% and 80-90%, but the variations in death rates are 2 to 3 orders of magnitude. And in fact, if you look at the correlation between the two, the correlation is actually negative. That is, more contacts and more death rates are correlated, which suggests more of a synergy view, not the trade-off view. The third line of evidence, looking at the similar trade-off or synergy question, is looking at death rates again on the y-axis over the last 6 months and changes in mobility. So we use mobility data from Google mobility trends, looking at daily visits to workplaces and retail and recreation venues against death rates. And again, we see a negative correlation that is statistically significant, which again suggests the synergy perspective. So overall, is there a trade-off between saving lives and livelihoods? No, actually the synergy view is much closer to reality. And that's actually consistent with what most of you voted for. And there is a good reason for that. So at lower levels of prevalence, you have more opportunities to target people who are at risk or people who are infected using contact tracing and then quarantining. And that makes it much less costly for the whole society. You don't need to go with mass lockdowns. There is a lower chance of overwhelming testing, tracing, treatment capacity. You wouldn't be burning out your healthcare providers. So that also saves you lives and saves you in terms of lowering the cases with reduced costs. and you have more time to plan and act when the numbers are low. It buffers you against possibility of more infectious or more virulent variants of the virus. And finally, when the case numbers and death numbers are low, you're building trust between the citizens and governments, which help the community respond in the next waves more effectively. So all of these come together and overall provide a little bit of a buffer against potential the increased cost of bringing down the pandemic. So that creates the synergy. So let me take a couple more slides and talk a little bit about vaccination results that we have found as well. So the key question on the vaccination side is, should we vaccinate vulnerable or the least responsive? Should we vaccinate based on vulnerability? So elderly and people with comorbidities have infection fatality rates, IFRs, that are more than 1,000 times higher among than children, let's say. So that suggests we should first vaccinate the elderly and people with comorbidities. On the other hand, people who are younger, who have more contacts or cannot reduce their contacts, they are the main channels through which the epidemic spreads. So that argues for first vaccinating people who are least able to change their behaviors. So there is a kind of a tension here, and it is not obvious what the correct answer is. You actually have to build a model to make that trade-off. And actually, several people have been working on this question. An interesting paper that came out just a couple of weeks ago in Science was looking at this trade-off. And essentially what folks in that paper suggested was that you should first vaccinate the elderly, because that minimizes the overall death rates. Even though the number of cases might be higher, that's the solution. But in that paper, they were not accounting for these behavioral responses that we have found to be so important in various questions we have addressed. So what the analysis we did was to add the behavioral response to the model that was published in Science. And here is what we get. So on the left-hand side, we have the results without having that behavioral response. So this is the results from the Science paper that I mentioned. And what we are seeing on the y-axis is the ratio of total number of deaths after the vaccination starts, with a policy of elderly first versus the policy of high contact people first. So this number is below 1 across both in terms of the number of deaths and the number of years of life that is lost, which means elderly first is better if you are using a model that doesn't account for these behavioral responses. So a number below 1 suggests you're having fewer deaths with the elderly first policy, no matter how long your vaccination period is, whether you vaccinate over 100 days or over 500 days. On the right-hand side is the same model, but includes the behavioral response, which actually improves the fit with the data significantly in this case. And here we see a complete reversal of the outcomes. That is, what we find is that vaccinating people who are less responsive or have higher contact rates actually minimizes the total deaths, even though the infection fatality rates are much lower for these groups. And the basic intuition is that folks who cannot bring down their contacts, they end up increasing that inherent equilibrium of death rates, because they have to be exposed to much higher death rates to be compelled to stay home and bring down the overall transmission. So if you first vaccinate them out of the system, that significantly reduces the costs. So that's the basic intuition. And let me now kind of summarize what we have found so far. So 7 times more cases, about 40% more deaths than officially recorded, wide variations across nations that are in the order of 100 times differences in death rates. And that is largely explained by different responsiveness across different communities. That behavioral response removes, interestingly, the trade-off between saving lives and livelihoods. It reduces the early impact of vaccination. It leads to prioritizing vaccination for those who are who have very high contacts or are unable to reduce their contacts. For example, residents in congregate settings, first responders, vulnerable service workers, communities with highest death rates. And we have the simulator that you can explore various alternative scenarios in at your own leisure. So let me pass it to Peter, who can manage the Q&A process, and we are here to answer any questions.
Great. Thank you very much, all three of you. There's an awful lot of information there. We've been getting a lot of questions coming in the Q&A. Please do keep them coming, and the team have been answering a lot of questions in the chat if you've been asking them there as well. You know, as I'm scanning some of these questions in the chat and looking at the data and the kind of policy recommendations that you're implying here, I'm getting a sense that there's also a question of almost fairness and equity. For example, in the last slide that you showed, Hazhir, you talk about vaccinating the population that is unable to reduce contact. But it seems like there's a lot of questioning of, well, how do you differentiate between people who are unable versus unwilling? And there's some kind of connection between behavior there and policy. And I'm wondering if you get to that degree of separation between those two types of reasons for not reducing contacts.
So, John, go ahead. Do you want to?
Yeah, so there's many reasons for that, but I think one of the most important is that there are many people in the United States and other countries who cannot easily reduce their contacts because they work in the service industry or in other jobs that require them to be physically present in the workplace. Restaurant workers, rideshare drivers, healthcare workers, health aides in congregate settings like retirement homes. And in addition, whereas people like us here at MIT, we can work at home, but many people in the United States and other countries simply cannot. So they have a difficult time reducing their contacts. In addition, many of those people are moderate and low income individuals. And that means that they are far more likely to have to take public transportation than people who can ride it privately, individually in a car. And that exposes them to the risk of transmission as well. And many of the poor and moderate income folks who are in these situations also live in more dense housing and in multi-generational households. It's unfortunately true that many of those people are minority folks and people in communities of color. And so that is one of the reasons we've seen this grossly disproportionate impact of the epidemic on communities of color. In addition, vaccines are less available there. If you live in one of these communities, you might have to travel miles and change buses multiple times in order to get to the vaccine sites that are currently available, whereas more affluent people can find them closer to where they live and drive there. So what that means is that the people who are less able to reduce their contacts and who perforce have higher contacts than others tend to be the poor and the disadvantaged and folks from historically discriminated against communities of color. And that is one reason why the policy of making the vaccine available to these people on a priority basis saves lives, and not just in those communities, but saves lives everywhere, because it reduces the risk that those people who can't easily cut their contacts transmit COVID-19 to other people, including the elderly and those who are more vulnerable.
So, and we had a lot of questions as well about vaccine rollout and vaccine effectiveness, and obviously those are parameters within the model that one can adjust to a certain extent. But given what you also just explained, John, about if there's a segment of the population where, at least according to this analysis, we should be trying to target vaccinations. Earlier in the presentation, you also showed some aspects of the model that suggest that still the behavioral responses have an even greater magnitude effect. What is the magnitude of the challenge you see, therefore, of the supply chain issue that we're seeing with vaccinations? Particularly, some countries have really got much less access or longer timelines, as well as this question relates a bit to the new variants. What happens if the vaccine efficacy changes?
Yeah, so there's no question that the supply chain and manufacturing constraints are a significant problem right now. I don't want to go into that in too much detail. The critical thing is that governments all around the world and the different states in the United States need to do a much better job to get the vaccine out faster, more equitably, more broadly everywhere. That will certainly help. But the critical result is, even if we can vaccinate everybody in just a year from December when vaccination started, which is optimistic for many of the developing countries where vaccines are simply not available yet, and especially with the news from South Africa that they've halted the distribution of the AstraZeneca vaccine out of concern that it's not effective at the current variant circulating there. Even in the developing countries, the speed of vaccination matters, but it's more important that people continue and indeed increase their use of masking, distancing, and the other public health recommendations. And unfortunately, what we've seen just in the last few days is cases in the United States, for example, and in many other countries, are now falling. And people are saying, we've turned the corner. Case rates are way down. And it's true, case rates are way down in the United States compared to the peak. But as of this morning, the number of cases reported every day in the United States remains 3 times higher than it was at the worst of the first peak, when most states shut down. And so what's happening is people are looking at the decline and saying, vaccines are working, we don't have to do anything now. I'm tired of staying home. I'm gonna go out to a restaurant. I'm tired of wearing my mask. I'm not gonna do that anymore. And what happens is that increases transmission, it increases cases, it increases harm, and it increases deaths compared to what would happen if people maintained their vigilance and adherence. And the impact of that behavioral effect is very large compared to a faster rollout of the vaccines within the plausible range. So this is not an either or, this is a yes and. We have to work harder to get the vaccines out as quickly, as broadly, and as equitably as possible. And while that's happening, which means throughout the rest of this year, most likely, people need to continue to adhere to the basic public health recommendations here. And if that doesn't happen, we're going to see a slower decline in cases and more deaths, avoidable deaths, than if people did adhere to what public health officials and scientists are recommending.
So thank you, John. We have some good students of system dynamics, I think, in watching today, because there were some comparisons early on or questions about the beer game. I won't ask you to explain that right now, but the argument or the point that people were making was, isn't this again an issue of human beings being very poorly equipped by evolution for dealing with systems that have feedback loops, particularly when there are time delays. And of course, there is the classic time delay issue between being exposed, becoming infected, being infectious, and becoming symptomatic or tested. There's decades of experience of trying to apply system dynamics, systems thinking to challenges around the world. What have you learned in all those years that's we need to be implementing from a policy perspective now, as individuals, as managers, as leaders?
Well, so this is a huge topic and a very, very deep question. I think my view, Hazhir and TY, feel free to contradict me. My view is, sure, people do have difficulty dealing with complex systems with long time delays and multiple feedbacks, but it is something we can and have learned in many important systems in the past. And just as an analogy, the world successfully eradicated smallpox. The world is on the cusp of successfully eradicating polio. And these highly infectious diseases have many similarities to COVID. So this has been done through a combination of public-private partnerships, through the hard, sustained work of hundreds of scientists and thousands, hundreds of thousands of individuals all around the world who serve in often hazardous conditions as vaccinators, and who go out into communities and patiently, carefully explain why getting vaccinated against polio can save lives, not just perhaps the lives of your children, but the lives of other children in your community. And so we have done this kind of thing before. We can rise to this challenge too.
I would add to that, actually the variation we see across countries is pretty large. So that suggests some places are doing actually a pretty good job of being responsive, of minimizing deaths and maximizing their economic activity to the extent that is feasible under a pandemic condition. So I think it is not a hopeless case that everybody falls into the same trap, but there is quite a bit of room for doing much better. And some countries are doing much better. So we can learn from them. And I think that's a positive spin to this.
Great, thank you. I'm just scanning some.
Did you want to comment?
Go ahead.
Okay, we're good, Peter. Go ahead.
I'm just scanning to make sure I haven't missed any important questions here. One of them, I think you talked, perhaps you can dive a little bit deeper into trade-off or synergy. You described in what the model shows in that. I think people perhaps struggle with that conceptually, being the result. So could you say a little bit more about this question of trade-off versus synergy in terms of what appear to be the huge economic costs to most people just watching the news or reading the newspapers or whatever their source of information is? How does that what we're perceiving square with what you're suggesting in your model?
Yeah, so I can start and give it back to John to give a kind of an analogy that we have developed around this. But the basic point is not that there is no economic cost. There certainly is. And that economic cost, the point is that it is baked into the system. As long as we are not willing to let 0.5% of the population die from this epidemic, we will be forced to pay an economic cost that is about the same across different nations, because that is the economic cost built into bringing down interactions enough to keep the reproduction number around 1 for your given society. And there is even a little bit of a synergy. That is, if you get that reproduction number to 1 at a lower case count, a lower death rate per day, you actually do get a bit more chance for productive economic activity in the society. So you can think about it as kind of a firefighting in a forest fire example. John, do you want to share that analogy?
Sure. So, it's a plausible analogy to compare the pandemic to a wildfire, both spread by a reinforcing exponentially growing process. They can spread all over. The wind can carry embers and start fires in places that haven't had outbreaks yet. This is how COVID spread around the world so quickly through travel networks. So how do responsible firefighters in a wildfire situation behave? Well, what a responsible firefighting organization does is, first, they're constantly monitoring for signs of smoke and fire. And the minute they get a report, they're out there with sufficient resources. If the fire gets going and gets large, they bring in the resources they need. People are forced to evacuate. There's mandatory evacuations, disrupting their lives, their children's schooling, and their businesses and economy. And they work hard to put out the fire. And then they don't go away. They stay and make sure that hotspots are truly extinguished. They keep units out there at great cost to monitor for outbreaks from embers and so forth. and people aren't allowed back until it's safe. That's what responsible firefighters do. And that's analogous to the response of countries like Singapore, Taiwan, New Zealand, that have had very low death rates per capita and aggressive immediate responses, but then they're able to more or less go back to normal life while remaining vigilant. What irresponsible firefighters do is they say, okay, we've got to get out there, there's a wildfire going, and they put enough effort in to get the amount of land that's burning to start going down. And then they say, look, the fire is getting smaller, we're making progress. Everybody who was evacuated, you can come back now. And all these firefighting units, they're very expensive. Let's go back to the station to save money for our towns and cities. And of course, the minute that somebody does that, the fire will grow again and the wind will carry embers to new places that hadn't been burning before. And so over the course of the full fire season, more resources will be spent, more disruption and evacuations will occur. And so the economic cost and the damage in acres burned and lives lost and disruption is higher. So that is another example of why there's no trade-off, and in fact, a synergy here. No responsible firefighting organization would behave that way, but that's the way many nations have behaved in this pandemic. A premature rush to reopen and allow people to go back towards normal contacts and removing mask mandates and so forth. And no surprise, that leads to a larger rebound in cases, which forces new lockdowns again. The total cost is higher, more people die.
As you were talking, John, and before there were some questions, and you mentioned some that might be described perhaps as outliers, countries that you mentioned that have perhaps behaved differently from a policy perspective and see a difference in the numbers. From your model here, does it seem to be that simple, or are there fundamental differences that other countries like the US or the UK, or even within countries, California in the US, seem to go on a different trajectory? Is that a consequence of the factors that you're seeing in the model, or are there other things that go beyond that?
Well, so nothing is simple in this pandemic, but we have looked at all the different potential explanations that are out there and that we could think of to explain the more than a factor of 100 difference in death rates over the bulk of the year of this pandemic so far. And the only explanation that stands up and is consistent with the evidence is the differential responsiveness of the populations and the governments. And of course that they are linked. If you have a population that opposes masking, that will not adhere to recommendations on avoiding large gatherings, et cetera, the political leaders in those regions are less likely to impose those until the situation is extremely dire. And of course, if you don't have those policies, the message goes out that it isn't necessary. So there's a strong feedback loop between the public's views, the behavior of the governments, and what happens. And we've seen this in the last week. Cases in Massachusetts in the United States are falling, and we are reopening restaurants and other businesses. In Massachusetts, the restrictions are being relaxed as of yesterday, and essentially every public health person in the state has been warning that that's the wrong thing to do. And it's already showed up as clusters of cases in various towns in the Commonwealth. So it is a little surprising, and we didn't anticipate this, but adhering to stronger, what are called NPIs, non-pharmaceutical interventions, masking, distancing, restrictions on indoor dining, and so forth. These are more influential and save more lives than even plausible, faster rollout of vaccines. But as I said, it's not either or, it's yes and. We need to be doing both.
So maybe in the last couple of minutes, we've been getting a steady flow of questions, which fairly or unfairly are perhaps asking you to make some predictions, based on what you actually just explained, that we might not see public policy or even individual behavioral responses which are optimal relative to the insights that you're getting from this model, based on what we're really just seeing happening. Do you have a sense of what the most likely or the more likely set of scenarios are? And what are the implications for how long this might go on for?
So essentially, the best that we can say is based on our quantitative model, and that's available to anybody who wants to run those scenarios with reasonable, realistic scenarios for developed countries who can vaccinate their population in the next 6 to 8 months. The bulk of the pandemic will be over in our simulations by midsummer. Where vaccination is slower, it can have another surge next fall, depending on how fast the vaccination is happening. But by and large, for most places, our projections are that we will be over the bulk of pandemic by late summer, early fall. Again, you can look at the specific country projections, and this is without any changes in the behavioral response function we talked about. If we do have changes in behavioral response function, and going back to your previous question, yes, there are kind of political and social constraints that limit how much responsiveness can change, but they are not kind of set in stone. In fact, those responsiveness levels have been changing over the pandemic level, and we see that in the adherence fatigue question. And we see in some countries, like interestingly, Iran brought down their death rates by a factor of 5 over 1 month and has stabilized it over there in the new death rate for the last 2 months. So you could see significant benefits over the next 6 to 8 months from just a little bit more policy responsiveness.
Let me just say that our model does allow you to try different scenarios. I would not interpret those as projections. And most importantly, we're not interested in predicting what's going to happen. We're interested in improving the outcome. This is a classic case where what we face is the opportunity to do better and not try to predict what's going to happen. I think if we follow some of these recommendations, which are consistent with what most public health and scientists are saying, many more people will be saved, fewer people will die needlessly, and the economy will be able to reopen earlier.
Thank you. On that note, which I think I can take a positive message from. So thank you for sharing this important research with us. I know many people were interested in asking how they can learn how to develop or use more about these sorts of models in system dynamics. John and the team at MIT do teach these concepts and these tools in a variety of courses and programs in different areas of application. You can see some of them here on the screen. I encourage you to take a look at those. We'll be following up with a blog article on the website as well, where we'll try to get at some of the questions that we weren't able to get to today. And I think there'll be a lot of news coming out in the coming days and weeks that will help you understand what's going on here as well. Thank you for joining us for this webinar. Let me just perhaps give a quick plug to the next webinar, which will be on February the 23rd from Innovation at Work at MIT Sloan Executive Education, where we'll be exploring the topic of digitally savvy boards and leadership teams, and how and why that pays off. So business continues even while we're struggling with the consequences and implications of the pandemic. Thank you all for joining us today. Thank you to the team here at MIT for this fascinating presentation, and the production team that have helped put it all together. We look forward to seeing all of you at future Innovation at Work webinars. And everyone, please pay attention to these messages, be safe, and we look forward to engaging with you all again in the future.